Hi everyone. This is a recent talk I gave for the cardiology fellows. It's very pertinent to us as well. I was planning to give this talk to our own residents next month. So I'd signed up for a grand rounds next month, but we'll go from here. So I've made it a very case-based so that we can keep it little crisp and not get too bored about it. But if you have any questions along the way, do ask me what's going on. Okay, so this is the case one. This is intermittent claudication in a healthy, athletic 30-year-old male in both calves for several months. So this is a 30-year-old man. He's got intermittent claudication, bilateral lower extremity, and he's athletic. So the first ultrasound that we see over here is, I don't have a pointer. I don't know if this is a pointer. This one? Or drawer? This is a pointer?
Yes, this is a pointer.
Oh, okay, thank you. There's a pointer too. Thank you, Dr. D. All right, so here I'll just let you know this is the right and this is the left popliteal artery. So in the right popliteal artery, here we're seeing that, of course, it's abnormally dilated, and then there's swirling of blood, or the yin-yang sign that's occurring within the popliteal artery. There's red, blue. What does that mean? That the blood is going at 360 degrees within a cavity, and that's when the blood swirls. And on the left popliteal artery, again, it's very enlarged. It is aneurysmal, and you're seeing a thrombus. So right from here, you're seeing that there is an abnormality, which is arterial, which is in bilateral lower extremities in a young athletic male. So that should come up with some broad or some narrow differential diagnosis. Any clues here? What we could be looking at? So both popliteal arteries are very abnormal. Patient is young. One is showing an aneurysm, and one is showing thrombus, both aneurysms, one patent, one thrombosed. So usually, okay, so look at this. Arteriogram, which is obtained at DSA, depicts this is an aneurysm of the popliteal artery right here, right? And of course, incidentally, we find out that there is an abnormal high origin of the anterior tibial artery. So this is the distal superficial femoral artery. We see the popliteal artery, which is dilated, so there is an aneurysm. And this is just a normal variation that there's a high takeoff of the anterior tibial artery here. So that was the patient. Any possibilities, any diagnostic thoughts here? Okay. This is again an arteriogram, which is obtained in the same patient, but here we had the patient do plantar flexion. Okay, so plantar flexion is this way, dorsiflexion is this way. So we had the patient plantar flex, the same patient, and that shows vascular occlusion of the popliteal artery. Same patient here. This was at rest, and this was on plantar flexion that we see that there is occlusion of the popliteal artery. Any thoughts here? Yes. Entrapment. Very good. So this is a Doppler image. I didn't have any cases of my own. I have not ever stumbled upon a patient by myself, so I had to get them from the net. So this was just a patient at rest where you get the normal triphasic waveform, and here on plantar flexion, there's absent flow, right? So at rest, it's normal. On plantar flexion, it's abnormal. So we are talking about popliteal artery entrapment syndrome. So all these entrapment syndromes, what do they mean? That these are normal vessels or normal arteries, veins, nerves, what have you, that are traversing a defined anatomical space. In this particular patient, they are traversing the popliteal fossa. And then the pain or the symptoms generated from this are intermittent, especially when the muscles around them are overactive. Either the patient is like athletics or the muscular hypertrophy, etc. So anatomic anomalies may be seen in up to 3% of the population and are often bilateral. Individuals with well-developed muscles are more likely to be symptomatic. Usually patients are young sports persons, and you can have this majority under 30 years of age. So remember that majority of the patients are very young, are in their maybe teens or 20s, and the male to female ratio is 15:1. Another thing that's telling you that the men are more muscular, and probably this defined anatomical space is impinged upon when there is a change. So this is a image that shows us that there are known 6 types of anatomical derangements that can occur in the popliteal fossa. and therefore this popliteal artery entrapment syndrome goes from type 1 to type 6. And diagnosis has to be made by two modalities. Number one, either ultrasound or DSA, in which you are able to do a rest image and a plantar flexion image. And number two, by MRI, where you can actually see the anatomical abnormality associated with the popliteal artery. So let's see the type 1. In type 1, just remember, this is the popliteal artery here. This is the popliteal vein. This is the medial head of the gastrocnemius muscle, and this is the lateral head of the gastrocnemius muscle. In type 1, the muscle is normal. However, the underlying popliteal artery is abnormal. It has a very abnormal medial course. So that is type 1 entrapment. In type 2, what is happening is that the medial head of the gastrocnemius is very hypertrophied. Compare the medial head and the lateral head normally. They're usually about the same size. Look at the ones here. The medial head is marked more hypertrophy as compared to the lateral head. And the artery is normally situated, but the medial head of the gastrocnemius, because of its hypertrophy, manages to impinge upon the artery. In type 3, you have an accessory slip of the gastrocnemius muscle. This is a normal variant, and when this accessory slip occurs, it causes impingement upon the artery. As you can see over here, it's like a sling that anchors the artery down against the bone, and that is the type 3 impingement, in which the medial head and the lateral head of the gastrocnemius muscle are normal. The course of the vein and the artery is normal. However, the accessory slip of the muscle is to blame. In type 4 popliteal artery impingement, you have what is known as the popliteus muscle. The type 4 and 5, in both you have the popliteus muscle. However, in type 4, it is impressing only upon the artery. In type 5 popliteal artery entrapment syndrome, it is causing impression on the artery and the vein. So that is the difference between type 4 and type 5. Both have to do with the popliteus muscle. And type 6, the type 6 normally says that the artery and the vein have the normal course where they have, but there is abnormal lateral attachment of the medial head of the gastrocnemius. And when that happens, it causes impingement on a normally coursing popliteal artery. So these were the 6 forms of the popliteal artery entrapment syndrome. And at least when I was taking the boards, one was expected to know what is the most common type of the so what do we see here on this patient? So you see this patient on grayscale imaging. We see this intraluminal echo right here, and this is by the posterior wall of the popliteal artery. And when you do this color flow, you can see that this intraluminal filling defect persists. This is the popliteal artery, and this is in Spanish, right, Dr. Yeah. So this is the popliteal artery, and there's color flow aliasing here, telling you that this is a real clot, and it may be hemodynamically significant because there is color flow aliasing. Yes, Hunter?
Which type was the most common?
Anybody knows from here before I tell them? Type 2 is the most common. All right, so this is the grayscale. Now what happens when there is a clot like this within the popliteal artery? Two things can happen. Number one, that there can be stenosis of the popliteal artery. But what is this clot doing? The patient doesn't know patient has a clot. Patient is walking, talking, dancing, whatever. He's showering emboli. He is showering emboli, distal emboli, into the distal digital vessels, into the infrapopliteal arteries. And by and large, over time, unknowingly, he may have showered a wide variety of clots distally. So, so this was a patient in which this was seen on maybe the right lower extremity. You see a clot here, and there is color flow aliasing with a persistent filling defect. And on the contralateral limb, because of chronic erosion of the arterial wall, there is now a pseudoaneurysm that has formed. So chronic abrasion of the popliteal artery against a tendon, a popliteus muscle, or the medial head of the gastrocnemius muscle has caused a pseudoaneurysm over time, and this is what it is. So 3 things that we know from here. Popliteal artery entrapment syndrome is a hot favorite on the boards. They really want to question you about it because these entrapment syndromes, for some reason, are pretty much in vogue. And so the athletic young male having bilateral symptoms, those are very peculiar, very typical symptoms of popliteal artery entrapment. What are the differential diagnoses? Cystic adventitial disease of the popliteal artery and a thrombosed isolated popliteal artery aneurysm. Patient just has a solitary aneurysm. It's neither related to any collagen vascular diseases, not related to any inflammatory syndromes or popliteal artery entrapment. There's either thrombosis there or cystic adventitial disease. So I just want to speak a little bit about these entrapment syndromes. So where are you? You're really between a rock and a hard place. And we're going to talk about the clinical and imaging features of vascular compression syndromes. So what are these vascular compression syndromes? Vascular compression syndromes are clinical entities caused by entrapment of one or more blood vessels between rigid or semi-rigid surfaces in a confined anatomic space. It makes sense, right? So the popliteal fossa, the popliteal artery doesn't have any way to go. It's anchored by the bone posteriorly, by the gastrocnemius muscle posteriorly. It really doesn't have any too much of way to go. So all these entrapment syndromes are basically, like they say, between a rock and a hard place, that they are some form of entrapment between rigid or semi-rigid surfaces in a confined anatomical space. They cause hemodynamically significant disease, including arterial ischemia and embolism, like I explained to you. Venous stasis, of course, if there is a constant anchor along the popliteal vein or any other vein, there will be stasis of blood, and stasis of blood causes what? Thrombosis. And there can be hematuria in otherwise healthy patients, particularly in which kind of entrapment? What am I referring to when I talk about hematuria? What kind of entrapment am I looking at? Very good, nutcracker syndrome. So we're going to talk about nutcracker syndrome as well, because that is a cause of benign hematuria in which patients had a battery of investigations done, and you can't really find a cause of hematuria. First, let's talk about thoracic outlet syndrome. So there are three distinct types of thoracic outlet syndrome. It could be neurogenic, arterial, and venous, depending upon which anatomic structure is compressed. So that's pretty easy to understand. So let's look at this case. This is a 20-year-old lady with acute left arm pain that is intensified with exercise. So there's a young girl, again, she's got left arm pain, this is unilateral, and she is giving you the history that it intensifies with exercise. Remember that many of these patients can be painters. They'll say that normally my arm is okay, but when I lift up my arm to paint, I really can't paint for a long time. And that's kind of the history that you might get. So the most common cause, which we normally see, is having cervical ribs. Cervical ribs can be bilateral or unilateral, and cervical ribs vary very much on how much is the osseous component of the rib and how much is the fibrous component of the ribs. So whenever you begin a battery of investigations for a patient with suspected thoracic outlet syndrome, start with a chest x-ray. You see bilateral cervical ribs, you're done. You know that is the cause of thoracic outlet syndrome. Now here, you look at this. So this is a digital subtraction angiogram with the arm in neutral position. So the arm is in neutral position in the anatomical position by the patient's side, and shows a thrombus. And we can all identify that there is a very subtle intraluminal filling defect in this contrast column of the left upper extremity, DSA, involving the subclavian artery. We see, not only do we see irregularity of this, we also see a clot within it, within the left subclavian artery. Now we did this with complete elevation and adduction of the arm. So how did we do it? We elevated the arm and abducted it. So abducted and elevation is this overhead position. So this is the maneuver to cause the stress. All these compression syndromes usually have a neutral position, and then they have one extra maneuver that you can perform when you can stress out the space, when you can further narrow the space to what it normally was. So with this, it's overhead and abducted arm. And here, what do you see? Right away, you can see that on the arch aortogram, pigtail catheter is here in the proximal arch. You see that there is total lack of filling beyond the proximal subclavian artery. This is the same patient who was there in neutral position, and now with elevation and abduction of the left arm shows complete occlusion. And here, this is the arrow showing you that. So remember that when you are considering patients who have upper extremity thrombi, narrowing, aneurysmal dilatation, please have thoracic outlet syndrome within your differential diagnosis. If this is not on your differential diagnosis, you will not do the stress maneuver, right? If you're not considering thoracic outlet syndrome, you will not do the stress maneuver. Patient will get thrombolized, probably will get thrombolized, and if somebody is particularly wants, they'll probably put in a vascular stent. Patient goes home. Over time, because of the compression is not relieved, the stent will get degraded. There'll be wear and tear of that stent every time the patient picks up her hand. And who knows, there could be a pseudoaneurysm, there could be a stent rupture. So you've got worse things lined up down the line. So this is where you're talking about left subclavian. All right, so same patient. Remember, when there is a clot sitting in the subclavian artery, what does it do? It showers emboli whenever there is little particles that are coming off, and you can see this is embolism. This is the embolism of the ulnar artery. There is occlusion of the ulnar artery in the distal 1/3. Is there any question regarding thoracic outlet syndrome? Okay. What is the modality of choice for investigation? Of course, you want to start with the chest X-ray. Then I don't think you should really waste time with the CT. If you've not got your answer of cervical ribs, please progress to MRI. How does MRI benefit over CT? MRI is the only modality that can show impingement on the brachial plexus. CT cannot show you that. MRI can show you what is the impingement on the brachial plexus, what is the neurogenic form of the thoracic outlet syndrome. So this is a 16-year-old swimmer with 1 week history of swelling and cyanosis in the left arm. So this is our next patient. She's 16, again young, she's athletic because she swims, and she's got a unilateral upper extremity problem. So let's look here. This on the contralateral side, was a good image because it shows both the veins. This is the coronal reconstruction that shows this is the axillary vein on the right side. But look at the axillary vein on the left side. There is no contrast within it. It is occluded, right? It's thrombosed. So CT angiogram demonstrates left subclavian and left axillary vein thrombus, right? Is there any question here? None, right? Usually when there is an acute clot, that vein may dilate whenever there is an acute clot. So there we see that there is a cause for her cyanosis is this. Then of course, after doing the CT angiogram, one progressed to do the DSA. So Venogram obtained a digital subtraction angiography with arm abducted 90 degrees shows multiple axillary and subclavian vein collaterals with the presence of multiple. So here you see that you see a venous segment here. That is a normal venous segment here. And you see a normal venous segment here. These are nothing but bridging collaterals, right? These are, so that means, that tells us two things, that the clot that we saw on CT angiogram on the axillary vein on the left is not an acute clot because it has given it time to form collaterals. Collaterals don't form overnight. They take 6 weeks to 6 months to form depending on the patient to patient. However, so you see that their proximal subclavian vein may be patent. However, the distal subclavian vein and the axillary vein are all chronically occluded with the presence of multiple venous collateral channels. This was with the arm abducted 90 degrees. So you have abducted the arm 90 degrees. Now, Venogram obtained with arm adducted 24 hours later after venous catheterization and thrombolysis shows a patent irregular subclavian vein with an abrupt stenosis in the costoclavicular space. So, of course, patient came here with us. This was the presenting feature. So, what did we do? We did venous thrombolysis. That's very common. That's bread and butter in interventional radiology. You put in your catheters, park them at a particular spot. Here we may have parked them in the proximal subclavian vein. You can park from centrally. You can park even at the elbow. You can percutaneously puncture the vein and park your catheters here. You give heparin. You get whatever thrombolysis you want. It's not only local, but you're also getting systemic thrombolysis. After you have done the thrombolysis and you have successfully recannulated the venous segment, because now the bridging collaterals are no longer seen, you still see that there is this distinct shelf-like defect at the costoclavicular space, which is this. And classically, when there is impingement, the defect is called shelf-like. It's like one plane, just like a little shelf over here. This is in adduction, in neutral position, in normal position. This is Venogram obtained at DSA after thrombolytic therapy shows subclavian vein occlusion. Here you see subclavian vein occlusion, a typical feature of thoracic outlet syndrome when the arm is hyperabducted. So this is a very important case because it shows us a couple of things. Now mic has also gone out. Yes, back on. So what does this show? This is how the patient presented. You wanted to eliminate the bridging collateral, so you did percutaneous thrombolysis. On your adduction study, you showed this shelf-like filling defect. Same patient is patent, is on the table. You do a stress maneuver. You ask the patient to raise their hand and abduct it, and you are able to show that there is complete occlusion of the proximal subclavian. This is a couple of minutes following this. So if you don't suspect thoracic outlet syndrome in those subclavian arteries, subclavian veins, there's no way you will do the maneuver. You will not do a stress maneuver to prove it. This stress maneuver can be done comfortably with ultrasound also. It really starts at the clinic when they are able to palpate a radial pulse, and then they ask the patient to do these stress maneuvers, and they're no longer able to palpate the radial pulse or able to palpate a feeble radial pulse compared to the contralateral side. But if you are able to do this, this is diagnostic. There is nothing left. All you need to do is an MRI right now to see what is causing the impingement, what structures are causing the impingement, and finally take the patient to thoracic surgery, who will relieve the patient of those impingements. So very important case here, and I want you all to understand that this is the venous collaterals start filling up as soon as the normal or the patient's subclavian vein is occluded by compression, the collaterals start to fill up. Alright, so the thoracic outlet encompasses 3 anatomic spaces: the interscalene triangle, the costoclavicular triangle, and the retro-pectoralis minor space. So we'll look at each of these spaces. I'm not gone into detailed anatomy of each of them, but we'll talk about these. So there are within the thoracic outlet also, there are 3 potential spaces that can cause compression of the vascular or neural structures. Okay, so we're looking at the interscalene triangle. So the interscalene triangle is drawn out with this triangle right here. So the interscalene triangle, you have anteriorly, the scalene muscle is anterior, the middle scalene muscle is posterior, and the first rib is inferior. So let's just look at it right here. So they say the scalenus anterior muscle is anterior to this triangle, the middle scalene muscle is posterior to this triangle, and it is bordered by the clavicle or the lateral border of the first rib. That makes sense, correct? Those are the anatomical boundaries of this interscalene triangle. Now, this is what runs through this interscalene triangle. Basically a part of the subclavian artery, not all of it, a part of the subclavian artery, but 3 divisions of the brachial plexus. So when there is neurogenic form of thoracic outlet syndrome, consider interscalene triangle as the causative area of compression. Am I going too fast or is it okay? It's okay? Alright. Am I audible? My mic is not working. You can hear me. What about you, Robbie? Jane? Alright, so that was number 1, scalenus anterior, middle scalene muscle, and clavicle or lateral border of first rib, and you're thinking about neurogenic. Now you see the costoclavicular triangle. Now we have this, that was an anterior view. That was an anterior view. The patient is standing in front of you. This is a lateral view. So this is again the scalene triangle that we spoke about, the interscalene triangle that harbors the first, second, and third divisions of the brachial plexus, the anterior scalene and the middle scalene muscles, and also the subclavian artery that is partly housed during partial course within the interscalene triangle. Now you talk about this second triangular space, which is a possible cause of compression. This is the costoclavicular triangle. It is the most common site of thoracic outlet obstruction. So what is this bordered by? The clavicle. Right here you can see the clavicle superiorly. The subclavian muscle will be below. The subclavian muscle will be below, wrapping anterior to it, and the first rib and the scalene muscle posteriorly. So if you were to see, this is the scalenus anterior muscle, which will be posterior. The subclavian muscle will be anterior, which is resected, and you can see that there is the clavicle here. So this basically causes compression of the vein. So costoclavicular triangle is more venous occlusion. Like the interscalene triangle was more neurogenic occlusion, this is more venous occlusion because the subclavian vein travels through this triangle. So in our patient here, most likely it was a costoclavicular space obstruction because this was a venous obstruction or venous occlusion. Now we come to this retro-pectoralis minor space. It is not a very common cause of thoracic outlet syndrome. It's the farthest lateral of all the 3 spaces. It's located beneath the coracoid process and bordered by the pectoralis minor muscle anteriorly. As you can see here, the pectoralis minor muscle anteriorly, and the subscapularis muscle posteriorly and superiorly, and the anterior chest wall posteriorly and inferiorly. So basically what they're trying to say is, this is the anterior chest wall, this has been opened out for you. So this is the anterior chest wall, which is anterior to this triangle, the posterior chest wall, which is posterior to the triangle, the pectoralis muscle, which is anterior, and here is your subscapularis muscle, which is posterior. So this is a very small triangle, more lateral. The coracoid process of the scapula is the superior margin. So you can imagine it's a fairly lateral space in the shoulder joint, but fortunately it's not a very common cause or a common causative agent for thoracic outlet syndrome. Now we have completed thoracic outlet syndrome. Are there any questions? You know everything about thoracic outlet syndrome now? Huh? Somewhat? Okay. Coming next to the next entrapment is the quadrilateral space syndrome. Now quadrilateral space, like any other space, is a confined space which has nerves and blood vessels traversing through it, and at rest it may be normal, but there may be a stress maneuver which will be able to show some stress on this space and therefore symptoms of impingement. Quadrilateral space syndrome is a neurovascular compression syndrome involving the posterior humeral circumflex artery and or the axillary nerve in the quadrilateral space. So let's look at normal anatomy. We'll look at that in a minute. So this was a quadrilateral space syndrome I'm describing in a 55-year-old woman with chronic left shoulder pain. On examination, there was deltoid wasting and an abnormal axillary nerve EMG. So she has everything going for axillary nerve involvement because axillary nerve is the one that supplies the deltoid muscle. There's deltoid wasting, means she is not been, there's no sympathetic or muscular nervous infiltration of that muscle. The patient's pain worsened during the Lang maneuver. What is a Lang maneuver? External rotation of the arm with hyperabduction when the head is turned to the contralateral direction. So how do you stress this space? The quadrilateral space is stressed on the Lang's maneuver. Extension, external rotation, and you move the head and you're really stressing out this space in the proximal arm. That's where the quadrilateral space is. So we'll look at it in a minute. So this Lang's maneuver can be performed in the clinic. This Lang's maneuver can be performed in the ultrasound suite. This Lang's maneuver can be performed in the angio suite. Only when it can be performed is when the radiologist knows of such an entity and is able to perform that. So let's look at the quadrilateral space. Fortunate thing about the quadrilateral space is only two structures run through this space. So let's look at this anatomy over here. So this is the quadrilateral space right here, and this is the posterior circumflex humeral artery, and the yellow structure here is the axillary nerve. So this is the axillary nerve here, this is the posterior circumflex humeral artery here, and this is the quadrilateral space. So if I were not to show you the text slide and ask you what causes the quadrilateral space, it is the long head of the two slips of the long heads of the triceps bordered by the teres minor muscle. That forms the quadrilateral space. Does it make sense? Even though it is a quadrilateral space, it has only three real anatomical margins. Okay, so 1, 2, and 3, and this is your vessel and nerve that pass through this space. So here, what do we see? So we see a small kink. Again, I wish I had a magnifying lens, but I think all of you can see. I want to stress on the fact that this is a shelf-like defect. It looks like as it's a bar, as though somebody's just put a little bar, or it's like a shelf, like a shelf of the house. Like it's just a small rectangular bar that is causing impression. It's not a gradual, indolent, long impression on the vessel. It's very specific impression here, which is showing a kink in the posterior circumflex humeral artery, and this shelf-like effect tells us that this impression is not due to a thrombus inside, it's due to an extrinsic compression. Lang's maneuver. When we did the Lang's maneuver, it shows occlusion of the posterior circumflex humeral artery. As you can see in the previous study, the humerus is by the patient's side. We are in anatomical position. In the second image, arm is hyperabducted. Arm is raised, abducted, head is turned to the opposite side. Only when you do the Lang's maneuver and you're able to show that there is acute occlusion of this vessel, that means you have diagnosed a case of quadrilateral space syndrome. Now coming next to another entrapment syndrome called the median arcuate ligament syndrome. Any questions so far? At least one is familiar with the terms. Yes, Dr. Simmons.
What muscle will have atrophy in the quadrilateral space syndrome?
Teres minor.
Very good. Teres minor.
And deltoid, no?
Deltoid.
Teres minor and deltoid. Very good. Okay, now we come to yet another form of impingement, the median arcuate ligament syndrome. Also, I want to tell you that it's very commonly seen, median arcuate ligament. I think in the last 2 years, I may have diagnosed 2 or 3 cases, but not necessarily are the patients symptomatic. So that is what restricts this very fancy diagnosis of median arcuate ligament syndrome, that you see it in more people than are actually symptomatic from the disease. So median arcuate ligament syndrome, also known as celiac artery compression syndrome, is caused by compression of the celiac artery by the median arcuate ligament, as the name suggests. Then what is this median arcuate ligament? This median arcuate ligament is a fibrous arch that connects the diaphragmatic crura on both sides of the aortic hiatus. As you know, the thoracic aorta comes into the abdomen through a hole in the diaphragm. That's called the diaphragmatic hiatus, or the aortic hiatus in the diaphragm. And on either side, there is a fibrous slip, and that is the median arcuate ligament. The ligament normally passes superior to the celiac axis at the level of L1 vertebra. We will see some images. in 10 to 24% of the general population. So see, that's where my answer comes from. Almost a quarter of the population may be having this median arcuate ligament, but not everybody is symptomatic. Okay, of the general population, the ligament passes inferior and anterior to the celiac axis. So in normal patients, if this is your lateral view and this is the celiac axis, the median arcuate ligament will come here and take a turn here. It will never come and touch the celiac axis. It will just go anterior to it, above it. But in this 10 to 24%, it will either pass inferior to the celiac axis or touch it from on top. It's when it touches it from on top is it got a likelihood of causing some compression. In people with this anatomic variant, the proximal part of the celiac artery may be compressed by an abnormally low ligament, like I told you, resulting in hemodynamically significant symptoms. What are the normal, does anybody know what would be the presenting symptoms in patients with median arcuate ligament? No one?
Pain with expiration. Pain worsened by expiration.
What did you say, pain?
Worsened by expiration, there's no other clinical finding, like no other associated clinical findings to explain it. And there's weight loss before eating.
Postprandial pain. You're right, and we're going to come to that inspiration, what you said in a minute. There was some one-digit number, so I couldn't answer. So here we're going to be looking at images of median arcuate ligament syndrome in a 45-year-old woman with postprandial abdominal pain, intermittent nausea, and weight loss. Remember, for the mesenteric circulation, if you have two patent vessels, it will do. But how much symptomatic the celiac axis compression will be depends upon the status of the superior mesenteric and inferior mesenteric arteries, because they have a lot of collateralization between the two. If the superior mesenteric artery itself has got a ton of plaque in it, then this may well be symptomatic. Alright, so as I've explained to some of you, the way I remember it is that always in all angiograms, abdominal angiograms, look at the sagittal image. You must look at this image in which the sagittal image where the celiac axis and the superior mesenteric artery are coming off. This is a very classic hook-like impression. That's how I want all of you to remember it. Nothing else, no atheromatous plaque, no fibromuscular dysplasia, no other celiac artery compression etiology causes this hook-like etiology. So this is a very classic V-shaped or hook-like impression on the celiac axis. So this is a sagittal maximum intensity projection image obtained with contrast enhanced CT, shows a proximal celiac artery with acute upward angulation, abnormal indentation in its proximal part, and severe post-stenotic dilatation. Like Dr. D will tell you that in the past, when we didn't have very fancy ways of measuring the aneurysm, if there was post-stenotic dilatation in a vessel, that usually meant that the stenosis was hemodynamically significant, when you didn't have ways to measure the pressure gradient across the stenosis. If there was post-stenotic dilatation, which there is more, this is the normal caliber of the celiac axis, this is the area of compression, and this is the post-stenotic dilatation. So this is that V-shaped or hook-like angulation of the, okay. Now, like Carson said, that what is the stress maneuver of median arcuate ligament? Like everything else that is impingement, there is a stress maneuver. The stress maneuver is have the patient take a deep breath, and that is the stress maneuver. So this first image is when the patient is taking a deep breath. What is happening when the patient takes a deep breath? The diaphragm is contracting, right? Because the diaphragm is moving down. When the diaphragm contracts, the median arcuate ligament contracts. When it contracts, it intensifies its impression on the celiac axis. And this is on normal breath hold, when there is no significant impression or a very gentle impression. Half of you are asleep, but please wake up. Okay. Does it make sense? Is it okay? It's worse with expiration?
No.
It's worse with inspiration. Because the diaphragm contracts, the median arcuate ligament contracts, it causes more impression. This is the deep inspiration and this is the expiration. This is a breath hold. All right, now we come to yet another form of impingement, which is a nutcracker syndrome. Please pay attention. Okay, nutcracker syndrome. Any questions so far? Okay. Nutcracker syndrome, also known as left renal vein entrapment syndrome, is caused by entrapment of the left renal vein between the superior mesenteric artery and the aorta, with resultant stenosis of the left renal vein leading to increased venous pressures, increased capillary pressures, and hematuria. Now, intermittent asymptomatic gross hematuria is the usual manifestation. It's asymptomatic, you've done a battery of investigations, there's no stone, there's no mass, there's nothing. And in men, reflux from the left, remember the left gonadal vein, either testicular or ovarian, is draining into the left renal vein. On the right side, the gonadal vein drains directly into the IVC. So whenever there are problems with the left renal vein, whether it is stenosed by itself, whether there's a clot in it, or whether there is an impingement like in the nutcrackers, the left gonadal vein, the pressure will back up and patient will start having left gonadal vein dilatation with varices formation in the left scrotum, pelvic congestion syndrome in the women. So in men, reflux from the left renal vein into the testicular vein may lead to varicocele, left testicular pain, and infertility. All that is plausible, right? You're exposing the scrotum to a higher temperature because there is hyperemia, there's more blood in the scrotum, spermatogenesis cannot occur. In women, reflex to the ovarian vein may cause congestion in the ovarian and parametrial venous plexus and lead to pelvic congestion syndrome, which is characterized by genital, pelvic and thigh varices, dysmenorrhea, dyspareunia, postcoital ache and pelvic pain. So these are very vague symptoms and it can take decades for all these to be assimilated together and blamed on the nutcracker syndrome, is what I'm trying to tell you. Unless we know what we don't know, eyes will never see. What the mind doesn't know, eyes cannot see. Now we're talking about nutcracker syndrome in a 19-year-old woman with hematuria and left-sided flank pain. Alright, so of course I want you to focus here. So what is the CT angiogram? Demonstrate compression of the left renal vein. Let's look at the left renal vein. So this is the left renal vein here, correct? This is the abdominal aorta. This is the superior mesenteric artery. This is the right and the left renal vein. And what are these, John? Have you had a CT rotation? Okay, Daniel, you?
That's a dilated canal.
Yes, these are, yeah, tributaries of the gonadal vein. Very good. So these are the tributaries of the gonadal veins which are backing up. The more you go down towards the pelvis, you might see 3, 4, 5, 10, 20 venous channels. That just depends on how much collateral network there is of the gonadal vein. So CT angiograms are showing you that there is a compression between the aorta and the superior mesenteric artery in this interval. Does anybody know what is the normal caliber of this interval? What is this interval called? Okay, so this is, like the name is very simple, it's called the aortomesenteric angle or the aortomesenteric space, like the name says, aortomesenteric space or aortomesenteric angle. Usually they say if this is less than 0.8 centimeters, it is concerning. If it is above 0.8 to 1.2, it's kind of in no man's zone. But less than 0.8 is concerning. Here you see marked impingement of the left renal vein. There's pre-stenotic dilatation. There's dilatation of the gonadal veins here. And this patient is having hematuria, so that's not surprising. Okay, this is a sagittal image in which I want to show you that this was a normal lateral view. Always look at the lateral view in every CT angiogram. You're looking at the abdominal aorta, the celiac axis and the superior mesenteric artery, which have a parallel finger-like orientation. And look here, between the superior mesenteric artery and the aorta, you see this compression, you see a sandwich, and this vessel over here is nothing but the left renal vein. Okay. Normally, if you start looking now, normally this aortomesenteric angle in this patient is extremely acute. This is not the normal angle. Normally the vessel will take off at a more wider angle. Okay. Now coming next to the next impression syndrome known as the May-Thurner syndrome. So this May-Thurner, yes. Okay. Okay. Does anybody want to answer? I can answer if anybody wants to take a try.
Bypass it, get the surgery. Pick it up and move it around.
With the vein?
Yeah.
Okay, anything else? Anybody else?
Don't ask them.
Okay, Piyush, normally this is one of the indications where you can do venoplasty. Okay, don't put in a stent, just do a plasty, don't put a stent placement. Okay, surgical, like he said, surgical repositioning, etc. is usually, books say it's done, but I've never seen it happen. Never seen it happen. For May-Thurner syndrome, however, this surgery may really lock in. Okay, so May-Thurner syndrome is also known as the iliac vein compression syndrome. This Meghna syndrome again is not very common. You'll probably see once a year or something, but it's a hot favorite on the interventional radiology boards. I can tell you that. It is very, very favorite, and they really want you to know. And the reason why it is a hot favorite is because they really want you to identify, and there are some perverse mnemonics going around to remember it, and I guess you guys already know those, but the left common iliac vein is compressed by the right common iliac artery. So that is the thing. The thing is, the trick is to remember what is compressing what. So very easy way to remember is that always only an artery can compress a vein. Why? Because the venous walls are very collapsible. The venous walls don't have any endothelium in them or muscular layers in them. They do have endothelium, I take that back, but they don't have a muscularis propria in them. The arterial wall can be robust, not easily compressible. So always the artery only will compress a vein. So that's one easy way to remember. Second thing to remember is to remember how the right artery is compressing the left vein. For that, you please look for some mnemonics and you'll be able to get some. Not right now, little later. Okay, so in Meghna syndrome or Crockett syndrome, the left common iliac vein is compressed between the right common iliac artery anteriorly and the fifth lumbar vertebrae posteriorly. This is that Meghna's compression. Chronic venous stasis results from compression, may lead to deep venous thrombosis of the left iliac and femoral veins. So, when you're on ultrasound rotation and the patient keeps coming back with left lower extremity venous thrombus, please have that in your mind, that why only one extremity is being clotted again and again, not the contralateral extremity. That time the patient should go for a CT venogram. Alright. So, the overlying right common iliac artery may affect the left common iliac vein in two ways. Firstly, by physically compressing it. So, the artery may affect the vein by physically compressing it. And number two, by producing intimal hypertrophy with synechia formation due to repetitive pulsatile impact. Number one is the physical proximity, that one artery and vein are together and they are compressing each other. The second is, because of the compression, the venous luminal caliber decreases over time because of intimal hyperplasia. If somebody keeps bothering you again and again, like a vein, then it will response is endothelial hyperplasia, intimal hyperplasia, it will narrow. So one is extrinsic compression, second is intraluminal. Now this is the drawing that I'm going to show you, and this will probably clarify what we are dealing with. So drawings are showing that there is compression of the left common iliac vein between the right common iliac artery and the spine. So this is the IVC. IVC is formed by the right and the left common iliac vein. Abdominal aorta formed by the right and the left, divides into the right and the left common iliac artery. This is the area of compression in which this right limb or the right common iliac artery is compressing the left common iliac vein. This is the problem here. How does it look on CT? This is the artery, this is the vein, and this is the fifth lumbar vertebrae. So this is how this is squishing between these two. The contralateral or the right vein is normal in caliber. Are there any questions? Sorry, I'm getting a text. I think it must be from a text. Please call me 1 second. Yes, Renita. Yes. How loud is it? Okay, just go overhead. What about the ovaries? Okay. The thing is, I will not be, well, I will be become maybe in 10 minutes. Can you hold her? Okay, I'm giving the lecture. I'll be back. I'll be in 10 minutes. No, doctor, that's fine. The patient can wait. Thank you. All right, any questions about the Meghna syndrome? All of you know what is compressing what? Carson, you?
Yes.
Robbie?
Absolutely.
Aaron?
Yes, ma'am.
Okay. So Meghna syndrome in a 44-year-old lady with a history of oral contraceptive use, number one whammy, recent long flight, double whammy, and left lower extremity swelling for 2 weeks before presentation. So at rest, these patients are almost thrombogenic, but as soon as you give them some inciting factor, put them on oral contraceptive pills, take them on a long flight from here to maybe New Delhi or somewhere, then this inciting factor invariably results in thrombus, because as such it is narrowed in caliber, it is prothrombotic, but thrombus can form very easily. So this was a patient who had the syndrome, and then it presented only because she was put on oral contraceptives and went on a long flight. So this is this patient's lower extremities. You can see clearly that there is marked swelling of the left lower extremity. So this is the compression. We'll look at it minute by minute. Okay, let's see. So right here, What is this structure? Does anybody know? What? Yeah, so very easy way to identify artery and veins on CT is that the artery usually will maintain a robust circular thing. The normal veins will be oblong, rectangular, trapezoid, rhombus, whatever you say. They may not be robust and circular. They may have various more sausage-like appearance. So here you can tell that this is the artery, because they have a very round, if I were to take a compass and draw it, I would be able to. However, look at this sausage-shaped structure, very oblong, oval structure. This is the vein. And this is the vein that is really being affected here, which we hardly see. This is the left common iliac vein that is being compressed by the right common iliac artery. If you come to the next image, which is one section lower, we've come down. This was the culprit, the right common iliac artery. This was the right common iliac vein, which is normal. And this over here caused impression on this structure, which is now demonstrating lower down a thrombus within it. And this thrombus continues from the common iliac vein all the way up to the common femoral vein. Does it make sense? Okay. So these are just the venograms that were obtained in the patient in the prone position to show the venous thrombosis of the left common iliac vein, which is the arrow there, and thrombus of the superficial femoral popliteal vein. So they're just telling you that there was a patient who had Meghna syndrome, and they did the venogram, and there were multiple thrombus which extended all the way from the common iliac vein down here to the popliteal veins. Okay, now we don't really need to do that. This is another few 30-minute things on groin complications. So we can do that next time. But I think it's already 12:52.